in the large intestine secretion of bicarbonate is to neutralize the acid from bacterial metabolism. Calcium, iron, potassium, magnesium, and phosphate, all ions we've talked about that all do important things. They're all readily absorbed. Now, they're also modifiable. And we're going to talk about the calcium system in our endocrine chapter. We're not going to talk about all of these because, frankly, outside of hospital level nutrition, it isn't important in clinical practice. The calcium bit is because of osteoporosis, right? So we pay a little more attention to calcium absorption and its regulation than we do the others. But all of these are readily absorbed, and it's intuitive. In other words, the lower your level of magnesium, the more vigorously you'll absorb magnesium, right? The lower your level of phosphate, the more vigorously you'll absorb phosphate, right? So it is intuitive, it makes sense. Iron is kind of an odd one. Did I talk about lead poisoning in MedPath? Did I? And its connection with iron? Maybe I'll talk about it again, right? All right, so when we're iron deficient, we increase our absorptive ability of iron, right? So our iron absorption increases. Now the problem is lead, Pb2+, looks just like Fe2+ to the intestinal cells. So when a patient is iron deficient, okay, if they have an exposure to lead, they will absorb that lead extra well because the body thinks it's iron. This relationship is strong enough that when we encounter a child who has iron deficiency, we usually check their lead level too. Now, the other part of this, so you have the absorption issue. Iron is low, absorption is better, lead competes. When you're iron deficient, you also develop pica. Pica is eating things that aren't food. And it comes out of the animal kingdom. You know, we were talking about how minerals are rare. So like a horse or a cow will sometimes eat dirt. And it's not like they've gone crazy, okay? They're seeking some mineral. And there's minerals in the dirt. Now the problem with children who have pica put things that aren't food in their mouths, like paint or soil or dirty toys or whatever. So if you add pica, which is caused by iron deficiency, now they're putting things in their mouth that don't belong. You can see the problem. So they're increasing their risk for lead exposure because their iron is low. All right, it's a relationship. And it's clinically relevant. We test kids a number of times in their lives for lead poisoning, and that's one of the reasons why. Now, lead is not universally distributed in the country or in the world. It depends on where you're going to practice. Some places have a very high risk for lead poisoning. Some places have a very low risk. Your public health people will be able to tell you. In some big metropolitan areas, it depends on what zip code you're in, right? You know, like when I was a resident in St. Louis, there were a few hot zip codes where, like, when we would see a kid who had lead poisoning, we would like guess which of the 4 zip codes it was. And the reason for that is in that area, they did lead smelting for years and years and years. They processed lead, so it's in the soil, right? These aren't kids who are eating paint. Thankfully, the lead-based paint has practically disappeared. You still find it in industrial buildings and stuff, but not in most homes. So that's gone away. But it's still in the soil. So anywhere they mined lead, there's lead in the soil at usually significant amounts. The struggle is it doesn't go away. You know, Pb, it's a heavy metal, so it just sits there. It gets rained on and sits there. Stuff grows around it, it just sits there. The only way they get rid of lead, they literally come in and they take the top 6 feet of soil away. 6 feet, that's as tall as me, right? That's a lot of dirt. And you can imagine that no family could afford that, right? You can't just like, oh, well, come take 100,000 pounds of dirt off my property. Well, no one can afford that, so the public health people do it, right? Sometimes patients will have to move while they do it, but usually they're put back in their homes. So a little story on lead from that. The rest, potassium, magnesium, phosphate, all absorbed in proportion to what the body needs. Okay, last point. One of the things that students often think about nutrition is that we've reached the point where we can give you all the nutrition you need through an IV, right? We call that total parenteral nutrition. In other words, skip the gut. I want you to know, first time you've ever heard of this, that is a bad idea, right? It is very, very difficult to simulate or to fake or to do for the gut what it does for us. So, like when we have a patient on total parenteral nutrition, they have a whole team just for that, just for what goes in the IV bag, right? So it's very complex. And it's just a good reminder that what the gut is doing in terms of monitoring our levels and adjusting absorption is critical. So amino acids and small peptides, co-transport powered by sodium, sodium powered by sodium potassium hubs, right? So got that one. Glucose, co-transport again, sodium falling down moves glucose up. Fatty acids are directly absorbed because they're polar molecules, right? The fatty acids, they're not in my picture, I don't think. The fatty acids come through the brush border. They make their way, they're moved to the smooth endoplasmic reticulum. They're put back to triglycerides. And then inside the intestinal epithelial cell, chylomicrons are made. The fats are loaded into them. The chylomicron is released into the lacteal, and then it travels into the blood and eventually gets there that way. Okay, now from there, well, we'll talk about it after the test, but chylomicrons go to the liver and are modified again after that. Now, the bile salts. Okay, so emulsification by the bile salts makes these micelles. Once this is done and the lipases break this down and the fat is absorbed, all that's left are the bile salts, right? So the bile salts end up going, right? So if this is the duodenum, right? This is the jejunum. This is the ileum, right? Don't show this to Amy, right? This is the colon. All right, so bile salts are put in here. They do their emulsification job along here. About the time they get here, the fat digestion and absorption is done, right? So now the bile salts come to the terminal ileum. They're reabsorbed, moved back to the liver where they're released again, right? That's that enterohepatic circulation of bile salts. It means that the liver doesn't have to keep making new ones, right? They are a little bit challenging to make. So the world's worst picture of the GI tract, but hopefully that made my point. All right. So it goes around over and over again. This also explains, this terrible drawing, also explains how you can live without a gallbladder, right? So very often, like patients have gallbladder problems, we go and we take the gallbladder out. Well, what happens to the bile then? The bile salts are then constantly recycled because there's no place to store them, right? There's no bladder, there's no gallbladder to put them in. So the liver is still making bile salts all the time, but this hepatic recirculation becomes the way it's handled. Now, students often ask, like, well, is there a downside then to having your gallbladder removed? Yeah, there is, because your gallbladder concentrates those bile acids. Okay, so it means that people who've had their gallbladder removed are less tolerant to fats, right? So big, heavy, fatty meals, sometimes they'll have discomfort or even steatorrhea because they don't concentrate their bile acids as well.